How you doing, Eric? Vice President. Good. All right. It's easy being Vice President. You don't do anything. It's like being the grandfather not there. Yeah, that's it.
All right, everybody, let's get started. Okay. All right. There were several people who were still in the queue who didn't have a chance to speak prior to us breaking. The topic was still insurance reform, although obviously these things interrelate, and I suspect that people may, have some other issues that they want to raise. After this, we're going to go to the issue of deficit, and which touches on some of the issues related to Medicare that have been raised already. And I'm going to actually have Joe Biden open that up.
Mr. President, before you leave, health reform, could I get on the list? I didn't know. I thought the whole thing was going to deal with health reform.
Well, no. I mean, we will be talking about health reform, Charlie. I guarantee you will be called on before. You'll have a chance to talk about all these issues. All right.
Mr. President, what time do you expect to end the meeting?
My hope is that we get out of here. We're running a little bit late, but for having a lot of elected officials sitting around a table, we're not too late. My hope is that we can adjourn by 4:15. All right? Okay. 4:15. Originally it was scheduled to go to 4. We're starting a little bit late on this front. So we'll see if we can get out here by 4:15. All right? That will require probably a little more discipline on all our parts, including myself, than was shown in the morning session. Although, let me just say that I thought the tone of the discussion was helpful, and I appreciate everybody's participation so far. With that, I'm going to go to Mike Enzi. I'm going to go to.
You're talking about leaving, Mr. President. Please put me on the list.
Well, I guarantee you guys are all going to have a chance to speak. But we're going to go to Mike Enzi, and then we're going to go to Tom Harkin. I know that we had Jay Rockefeller was still on the list. Was there another Republican that wanted to speak just on the insurance reform issues, or you want to go to John Barrazo? All right. We'll let you guys split time on this one. All right, Mike.
Thank you, Mr. President. Colleagues, when we're talking about insurance reform, we haven't really talked about, but Representative Slaughter kind of opened the door on it, and that's Medicare. Seniors out there are really nervous. Seniors are the ones objecting the most to the program, and it's because they see $500 billion coming out of their program. If Medicare were separate and any savings that we did in Medicare reform went back into Medicare, it would do a lot to relieve the tension that's out there. It'd even be a way to pay for the doc fix. So I'm hoping that that can be a piece of what we're doing. I really appreciate this exchange. It would have been helpful had we had this 9 months or a year earlier and had it in even more detail and for more days. What we were presented with in the Help Committee, of course, was a bill that was already half drafted. And we started the markup on it, and then we got the other half later. And since we had not had any input to the drafting, we're credited with 150 amendments. Well, 17 of those amendments were Senator Murkowski, where she was inserting Native Americans and tribal in 17 different places. I had 11 of them where we put in a thing that required agencies to cooperate. So the ideas that we had, when Senator Kennedy and I were working bills, we'd set down some principles and then put some detail in and then draft the bills together. And I hope that that's something that we go to on future bills. It works. In a 3-year period, he and I got 38 bills signed by the President. In the last year, I've gotten 2 that I've gotten pens from this President. And the way that we've done those has been through that kind of a process. And unless we go through that kind of a process, I don't think we're going to. I don't think we can get to the bipartisan thing. And that's what the purpose of this meeting is to kind of get all these ideas together and see how they gel. In insurance reform, small business health plans, that's different than the AHPs, which is what they were talking about, and it covers some of the problems that were talked about. One of the problems is mandates, and Olympia Snow contributed to that part. She had a provision that if 26 of the states adopted a mandate, it would be a mandate nationwide. And as other mandates became 26, they'd be included with it too. We talked about health savings accounts. I don't think that meets some of the federal minimum standards that the federal government might put on it. And that's going to disappoint some of our employees, because that is one of the options that federal employees have, is health savings accounts. And it's particularly good for the younger, healthier people. They can get that. They've got catastrophic coverage. If they put the amount of money that they would have spent on a Blue Cross plan or some other plan, the difference between the two, into a savings account, in 3 years they've covered the huge deductible. And they can continue to do that tax-free. So it's a process that would be really objected to if it's excluded or changed. I like the exchanges, and the reason I like the exchanges is it's kind of a form of bidding. It's more transparency. People can see what they're buying, and that would be a big help. When we were in the shoe business, my wife used to, after 10 years, she decided she'd bid out our insurance. We didn't know there was that much flexibility in insurance. She saved a bunch. And then, of course, she didn't, since we were selling shoes, it's kind of a fixed price, so she didn't really take the low bid and then go back to somebody else and say, can you make this a little lower? But that insurance company we'd been with for 10 years came to us and said, we could have done a better deal. She said, you should have when I was buying the insurance. And we got much better bids the next year. So these exchanges can be good. But what I would hope you would consider is having the exchanges to list anybody's insurance that wants to put it on there, and then mark the ones that meet the federal minimum standards, so that people can decide really what's out there in the market. And I think it would pull up some of the ones that are lower down up into the category, and at the same time everybody could see what all's on the market out there, and hopefully regardless of states. Thank you, Mr. President.
Thank you very much, Mike, and thanks for staying succinct. Thank you very much. And I thought you shared some important ideas there. Tom Harkin.
Mr. President, thank you again for bringing us together today. I think, if anything, what I've learned here so far is that, quite frankly, we may be closer together than people really think in actually getting agreement that we can move forward on. I hope that's the case. There's been a lot of figures thrown out here and a lot of process things, but I keep thinking we got to bring it back home to what this is all about. We all have our stories. I got a letter yesterday from a farmer in Iowa. It really encapsulates it. I'm a 57-year-old Iowa farmer. I'm writing to voice my concern regarding my family's rapidly escalating health care costs. On Saturday, February 20th, I received a notice from well-marked Blue Cross Blue Shield of Iowa informing me that our health insurance premium will be increasing $193.90 per month to a monthly total of $1,516.20. This is a 14.6% increase and will result in a yearly cost of $18,194.40 for a family of 4. 10 years ago, our monthly health insurance premium was $373.50 per month for a similar policy, which had a lower deductible and covered 3 additional children. Health care costs are out of control, and as a self-employed individual, I feel powerless. At the current rate of increase, by the time I reach Medicare age, my premiums will cost $42,000 per year. As a farmer, I manage risk on a daily basis. Weather, weeds, insects, and fluctuating commodity prices. I have not yet found a way to control my exposure to health care expenses. Because of pre-existing conditions, I've been denied access to coverage under more economical insurance plans. Therefore, I'm stuck in an expensive pool and have few options. The best option would be for the U.S. Congress to pass comprehensive health care reform, resulting in affordable health care for all. The health of my family and the future of my small business depends on it. Sincerely, Raymond Smith, Buffalo Center, Iowa. Mr. President, we spent, I hear talk about, well, we got to start over and do all this thing again. You know, we spent 1 year considering a range of ideas from experts from all over the political spectrum. 2 committees, the Health Committee under the able leadership of Senator Dodd, the Finance Committee under the leadership of Senator Baucus, held over 100 bipartisan meetings and walkthroughs to discuss this bill. Our bill contains over 147 distinct Republican amendments. Now, on the issue of health insurance reform, of the 10 key elements in the House bill, we have 9 of them in our bill. 9 out of 10, that's not bad. The only one that's missing is the health savings accounts. But 9 out of 10 are in our bill that are in the House Republicans' bill. Now, again, those, what are they? You know, again, pre-existing conditions, we covered that. No rescission when you get sick. No lifetime annual caps. No gender-based ratings. Keeping your kids on until they're age 26. That's in the House Republican bill. That's in our bill. So I think we're very close on. Last 2 things I just want to address myself to is this idea that somehow we can do a little bit. Somehow we can do insurance reforms, but we don't have to do anything else. Well, quite frankly, if we want insurance reforms, you can only do that if everybody's in the pool. You can only get everybody in the pool if you make it affordable for middle-class families and others. You can only make it affordable for middle-class families and others if you have cost controls. What I'm saying, Mr. President, and others, is this all hangs together. You can't pick one out and do it without doing it all together. It all hangs together. Cases in point. Some states reform without doing anything else. And they found it to be a debacle because the insurance premiums skyrocketed. New Hampshire, Kentucky, and Washington were forced to repeal their reforms because of that. Case in point, Massachusetts in the 90s put in health insurance reforms on anything else. Individual market premiums doubled. 4 years ago, when they did their comprehensive reform and they put the package together, premiums dropped by 40% in Massachusetts. That's why you can't do this incremental approach. Every time I hear about, you know, we're sinking, we're drowning in this country on health care. An incremental approach is like a swimmer who's 50 feet offshore drowning, and you throw him a 10-foot rope. You say, well, it didn't reach him, but we'll get it back in. We'll throw him a 20-foot rope next time. Then we'll throw him a 30-foot and a 40. By that time, the swimmer's drowned. And that's what's going to happen to Ray Smith and so many other families in this country. They're going to drown by the time, if we do this kind of incremental type of an approach that I hear others talking about. Lastly, I'd like to put this in a different kind of a contextual framework. We don't allow segregation in our country on the basis of race, creed, color, national origin, etc. 20 years ago this year, we also said we're not going to allow segregation on the basis of disability when we passed the Americans with Disabilities Act. And yet, we still allow segregation in America today on the basis of your health. Why should we? Why should we allow that to happen? It's time to stop segregating people on the basis of their health. That's why insurance reform is so vital. Because the health insurance industry in this country is based on a flaw. And the flaw is their ratings are based on segregating people because of their health. Think about that. Whenever I hear the word pool, this pool, that pool, this pool, I think segregation. You're segregating people out because of their health status. I think it's time to end that. I sold insurance. I was an insurance agent when I was a young man. And there's one principle of insurance I learned then that I've never forgotten. The more people in the pool, cheaper it is for everybody. You start setting up these pools, you're going to make it more expensive, and you're going to be segregating people on the basis of health. Let's think about that. It's time to stop that kind of segregation in our country.
All right. Tom, Dave Kane.
Thank you very much. On the issue of insurance reform and pre-existing conditions, there are responsible ways to solve this problem and reduce the cost of health insurance for everyone. And we support state universal access programs that address high-risk pools and reinsurance that makes affordable coverage available to those who are sick and those who have a pre-existing condition. And I won't go through all of those things that Dr. Bustani and others here have talked about. But and our approaches are somewhat similar on this issue pre-2014 in the period where the House and Senate bills are ramping up. But there is a pretty big distinction, and that is that there's a key difference in the approaches. We prevent waiting lists during that period, and we have these programs managed by the state level, and they're robust enough that CBO has scored that they'll be effective. And what the House and Senate approaches are is that those rules are set in Washington. And the House and Senate bills are similar in that if you look at the Senate bill on page 48, 51, and 52, it's the unelected Secretary of Health and Human Services who has the authority to establish waiting periods for access to these programs, raise premiums, reduce benefits. And so it is we are similar in what we talk about. There's a very key different approach there. And then after 2014, when the bill fully comes into play, you have a very different approach there, and what you do is establish pre-existing condition and link it with the individual mandate. And the American people have told us they don't want to be forced to buy health insurance that they don't want and they can't afford. And this is a significant issue across the country, and the American people are telling us that the individual the mandates, the requirements to buy insurance are something that they want us to scrap and start over on. And that's why you're seeing state legislatures around the country passing resolutions saying our citizens are going to have a choice on whether they buy health care. They're going to have a choice on the kind of coverage they want to have. And so this is a fundamental difference in this area of insurance reform that I think we have to really begin again and really take into what the American people are saying and expressing this through their elected representatives in the state legislators. I know there's a lot of former state legislators here. I'm one as well, and I think that's a very serious point that we need to address.
I'll just touch on your last point, which is the whole issue of pre-existing conditions. Tom Harkin mentioned it, but I'll be very brief because I know that we've got to move on to the next topic. The way I understand Leader Boehner's bill works, and I think that's the one you're referring to, the way you deal with a pre-existing condition is to essentially set up a high-risk pool. I mean, that's the mechanism. So what you're saying is if you're sick or older or you got hip replacements or what have you, and you're having trouble buying insurance on the open market, you're going to be able to buy into a high-risk pool. Now, Tom made the point earlier that, and this is indisputable, I don't think anybody would disagree with this, that if you set up a high-risk pool in which you don't have healthy people, younger people in the same pool as older, sicker people, the premiums for the older, sicker people who've been segregated into this pool is just going to be higher. Now, we looked at the Boehner bill to see sort of how you approach that, and you've got some reinsurance, and keep in mind we use a high-risk pool as well until we get to the exchange, and we have reinsurance, for example, for federal or for people who are on retiree plans. We want to help employers maintain those plans, and they've got an older population, so we want to help reinsure them. Given the amount of money that you have allocated for that pool, it's just not going to be a very useful tool for the vast majority of people who've got pre-existing conditions. Just because there's just not enough money that you guys put into it to be able to cover all the people with pre-existing conditions, which is why other states have high-risk pools Kathleen mentioned. I don't know how many states, but let's say 20, 21 states currently have high-risk pools. Out of all those 21 states, about 200,000 people use the high-risk pool. And the reason is because by just dealing with older, less healthy individuals separately, or people with pre-existing conditions, it is very, very expensive. Tom's point was, if everybody's in it, because presumably none of us know at any given moment who's going to end up being healthy and who's not. We don't know whether our kids are going to be suffering some sort of disease that we don't anticipate yet, or our spouses get ill. That if everybody's in it, then that drives prices down cheaper for everybody. So it's not that I think that the high-risk pool idea is a bad one. As I said, the House, the Senate bill, the proposal that I put forward, all use the high-risk pool as a stopgap measure to get to a broader pool, but the goal has to be to get everybody in a place where those risks are spread more broadly.
And if I just might say, we support high-risk pools and reinsurance with $25 billion in funding.
Right.
The House and Senate versions are $5 billion in funding, and because of that robust support, CBO says this will work. The fundamental difference after that is that the Health and Human Services Secretary, in that 4-year period when they're somewhat similar, has the authority to raise the premium. So all of that is brought to Washington. We leave that authority in the states so that they can manage their state pools. And then after the bill becomes effective in 2014, the real problem becomes the mandate and the cost, the forcing of the purchase of insurance, which many Americans find objectionable. And that you can avoid that mandate if you continue to design this as we do in the beginning.
Well,
and both plans are somewhat similar on that, but it's a very different structure.
What I'd like to do is to move on to the topic, which I think underlies...
Jay Rockefeller.
Oh, I'm sorry. We still got Jay. My apologies. Jay, please go ahead.
Thanks, Mr. President. We really haven't discussed, I think, what is at the basis of the frustration about this whole business of pre-existing conditions and lifetime limits, all the rest of it. And that is the way and the nature of the health insurance industry, for the most part. They are, among all industries I've ever encountered, and in the Commerce Committee we have spent a year analyzing and bringing out some of their sins and ills. They're terrible. They're in it for the money. A nice lady who runs WellPoint said, "We will not sacrifice profitability for membership. Money first, people second." We had a fellow named Wendell Potter who worked for Cigna for 20 years as a high executive. He came before us on his own, volunteered, and described the way health insurance companies operate. They are looking for reasons to kick you out. They are looking for reasons, if you already have the health insurance, for doing the rescissions. Yes, we're going to ban those, but not unless we pass a bill. And in fact, often employees are incentivized financially to find reasons to kick people off of the insurance which they're paying for. So you can be paying your premiums, and then they discover they come up with something they found in your background they don't like, and they just kick you off. They can do that now legally. And so people say, well, you know, maybe the states ought to do this, they can do it better. Well, that's the situation we have now. But 44 of the 50 states make it perfectly legal for health insurance companies to do this pre-existing condition, to simply deny coverage for something which people just got sick, as babies or as adults or whatever. I got a letter from the CEO of Cigna written to me, and he said, I want to apologize because we had said that we'd spent $5 billion on the small group insurance market. Well, I checked a little bit more. In fact, we hadn't. Now, why don't people know that? Because the health insurance industry is the shark that swims just below the water. And you don't see that shark until you feel the teeth of that shark. Now, unless I be accused of trying to over-dramatize my statement, this is the way they operate. Nobody has particular oversight of them. They're not under any antitrust type rules. They can do what they want. They so dominate the market, as the Secretary pointed out, that there really isn't any real competition. They can do what they want, and they do. And it's money. It's money. And it makes me sick. It shouldn't happen in America. People say, well, government run. You're going to do this or put that restriction on them. If you don't put the restriction on them, they're going to go on doing this. And so, you know, the public option was, I like that a lot, but that's not going to probably be possible. So you have to go at them to clip their wings in every way that you can. And that's why, and with his general agreement on pre-existing conditions and rescissions and lifetime annual limits, I mean, you know, it's not a lot of fun to see an 8-year-old kid, which I have done, and I knew this kid, Samuel Board, and he had leukemia, and he had life, you know, annual limits, and he ran out, and then he died because there was no insurance. Could they have cured his cancer? I don't know, but that's what insurance is for. So this is a rapacious industry that does what it wants, unknown in their behavior to the people of America, except on an individual basis, and individuals can't shake up us the way they're now doing it, I think. So when you talk about the individual mandate, that's not in there for some government makes that decision purpose. It's there because you got to have a big pool. Everybody's made that point. I got a son who's old enough to have health insurance. He doesn't have it. And when my wife and I found out about it, we told him to get it the next day. He didn't think he needed to have it. He would live forever. Well, of course, that's the premise among young people. That's why we have the requirement that people sign up for health insurance. And they don't know if they're going to need it. And he doesn't know that he's going to need it. So you make everybody participate, and then you have a bigger risk pool. You can do a better job. I want to say one word about medical loss ratio, because it's sort of a crazy name, but it's a really good concept. What we say is that the health insurance industry in Cincinnati says that they spend 87% of all of their revenues from premiums or any investment that they might have on health care. That doesn't work out quite that way. For large businesses, they do a much better job. But for small businesses and the individual market, they're down in West Virginia in the high 60s and the low 70s. So how do you stop that? You can't stop that by asking them to. You stop that by having a law, which is a good law, saying that you have to spend between 80 and 85% of everything you take in revenue on medical care for your patients. And if you don't, we will know about it because we'll be tracking it, and then you have to rebate that difference to the people. So there's a reason for doing that. It's good public policy. It can't just happen on a voluntary basis. I mean, but it's a way to make sure you get your objective. Let me just close on one other issue. The rate review, and I wish we could talk about the Medicare board, advisory Medicare board, which is controversial, but which is
well, we will have a chance to talk about it next. So,
well,
Jay, let's wrap it up because I want to make sure.
I'm going to wrap it up. insurance rate review is important. And if Kathleen Sebelius is to be called an unelected person, and she's head of the group that does all of Medicaid and Medicare and Health and Human Services, and she's been an insurance commissioner, she's been a governor, she knows the whole thing. I don't call her down because she's not elected, but was appointed by you, and it was a brilliant choice. People say decisions can't all come from Washington. Sometimes decisions have to come from Washington, because what we're about here is not trying to run by government. We're trying to protect consumers. And if you're going to protect consumers, you've got to have a way that they really do get protection, and that they know it, and that they feel it in their lives. So this insurance reform is important. It's a profoundly emotional subject out there, and we got to do something about it.
Mr. President, Ms. Blackburn was on the list, I thought, before we left.
Okay, go ahead.
Thank you, Mr. President. And yes, one of the points that we did want to cover today was the across-state line purchasing of insurance. You've alluded to that a couple of times and mentioned that you felt like we were close on that issue. I think that there are some very important structural differences in the way we approach this, just as I think that there are very deep philosophical differences in how we approach health care reform. Now, a lot of the people that I talk to want us to start over in this issue, and they want us to give them the ability to hold insurance companies accountable. One of those ways is through very robust competition. And when you have a district like mine in Tennessee, where the bulk of our constituents are within 15 miles of a state line, the ability for those individuals who have families and live and work and have employees on the other side of the state line who shop for major purchases every day is to allow them to be able to make those purchases. Also, when you talk about holding insurance companies accountable, if you want to empower patients in front of those insurance companies, take the power away from them, then give them the ability to buy a policy that suits their needs. They are really tired of paying for coverage they don't want. If you want to prevent premium acceleration, such as the issue in California right now, where the premiums have gone up 39%. If you are siding with protecting those insurance companies and not allowing across state line competition, then what you're doing is denying Californians the ability to go to Oregon, where they could buy a policy for 25% less, or individuals in New Jersey who could go to Pennsylvania and buy a policy and lower their cost 26%, or go to Wisconsin and buy one and lower their cost 74%. Now, some of the very differences in our bill, we have a way to do this without putting a federal bureaucracy in charge of it. States can already do compacts, but the Senate bill legislation would require state action and then federal approval for those compacts to take place. There's another important point here. The bill that you all are proposing would not put these in place until 2016. And quite frankly, I think a lot of the American people agree with us that care delayed and access delayed as care and access denied. And they would like to see those, basically what you have, state lines right now basically have stop signs up. When it comes to across state line access, they would like to see that come down and like to see those access portals opened up so that they can first lower their cost, secondly, so that they have greater ability to hold insurance companies accountable, and then also state legislators, even some of our governors, many of the governors favor approaching this model and allowing our constituents a way to access this, get the cost down, and I will be brief so that we can move on to other topics. Thank you.
Well, I appreciate that very much, Marcia. Just to close, because there have been two issues that were raised. One, the purchasing insurance across state lines, and the other was the issue of the mandate, and I just want to address those very briefly, and then I'm going to turn it over to Joe. I support the idea of purchasing insurance across state lines. And you're right that the way we structure it is to have compacts between states so that you start getting a regional market. But I think there are two things that are important to understand. Number one, with respect to California, for example, the problem, as was presented yesterday in California, was not that there were a whole bunch of insurance companies from other states who were clamoring in to get into California to sell insurance to those individuals who saw their premiums spike by 39%. There weren't. The problem has to do with the fact, according to them, that people who have lost their jobs now, who are healthy and can't afford the individual market, have basically just decided, I'm going to go without insurance. I'll see, I got to take my chances because I just can't afford it. What that's left is people who, because of pre-existing conditions, because of special health care needs, because of age, they have to keep their insurance. And so the pool has become older and sicker. Now, the way to get at that problem is actually what we've discussed earlier, which is to broaden the pool. Make sure everybody's in the pool. And that's what the exchanges do. I actually think that on the purchasing insurance across state lines, there may be a way of resolving the philosophical difference. Not entirely, but there's a potential way of bridging this gap, and that is to say that once there was a national exchange with some minimum standards, then potentially you could just have a national marketplace and anybody could be able to sell into the exchange. This is something that Mike Enzi just mentioned. I actually think that could be workable once the exchange was stood up. So there may be a way of bridging this difference.
Yeah.
Now, on the mandate, though, because the mandate issue is connected, and so I'm just going to mention this real quickly and then we'll move on. When I ran in the Democratic primary, I was opposed to the mandate.
Bless you.
Well, because my theory was, you know what, people, the reason they don't have health insurance isn't because somebody's not telling them to get it, but because they just can't afford it. And that if we lowered costs enough, then everybody would be able to get it. So I was dragged kicking and screaming to the conclusion that I arrived at, which is that it makes sense for us to have everybody purchase insurance. And I have to say, this is not a Democratic idea. I mean, there are a number of Republicans sitting around this table who have previously supported the idea of an individual mandate, responsibility. The reason I came to this conclusion is twofold. One is cost shifting, which is a fancy term for saying everybody here who has health insurance is one way or another paying for those who don't. Every time somebody goes in the emergency room, if Jay's son got hit by a bus and his dad wasn't Jay Rockefeller, and he ends up in the emergency room, we'd give him emergency treatment, and we'd all pick up the tab. And the calculation, not our calculation, but independent economists, is that each family with health insurance right now is picking up $1,000 to $1,100 worth of costs for people who don't have health insurance. So when Tom Coburn earlier said, you know, if a kid comes to the emergency room, they're going to get treated. Yeah, they will get treated. Who's paying for it? Well, we're paying for it. Every American family who's got health insurance is paying for it. Every employer who is covering their employees is paying for it. So we're already putting the money in. It's just in a very inefficient way. Now, if we don't ask people to carry their responsibilities, that we're saving money. No, we're not saving money. It's just we don't see it. It's called uncompensated care, and we all get charged an extra $1,000. So that's part of the reason. The second reason has to do with the issue of pre-existing conditions in the pool that we've already discussed. But I just wanted to address those two issues. Marcia, you had one thing that
Yes.
you wanted to respond to?
Yes, Mr. President, I did very quickly. I would just suggest that we're looking at this from, in your example, we're looking at it the wrong way. You're talking about letting companies into California. I'm talking about letting individuals out.
No, it's the same idea, Marcia. It doesn't matter whether they're companies are going in or people going out. I promise you.
Free it up.
No.
Free it up.
I promise you that the problem that's going on in California is going on in. It's not as if they're insurance companies that are given great deals in Iowa. That gentleman farmer who just talked about it, these are some structural problems that exist in every state. It is what is true.
Yes, let him
No, I want to say this. Hold on a second, guys. What is absolutely true is that some states probably have higher mandates than others, and so you can probably attribute a certain amount of the cost in a a state that has more requirements for bare minimum coverage, doesn't allow, drive-by deliveries or requires mammograms or what have you. Those things all may add some incremental cost, but the truth of the matter is that that's not the reason that you're seeing such problems. In a lot of states, the problem is just you don't have competition at all. We want competition. We just want some minimum standards. All right, Joe, let's talk about cost because, and now we're not talking about cost of families, but we're talking about deficit, how much respective ideas cost. I think this is a good place to talk about Medicare as well because it's been brought up several times. Joe, go ahead.
Mr. President, I'll try to be brief. There's a lot to talk about. I'd like to focus it, though, on the deficit, impact on the deficit, which we're all talking about. And I must tell you, maybe I've been around too long, but I'm always reluctant after being here 37 years to tell people what the American people think. I think it requires a little bit of humility to be able to know what the American people think. And I don't. I can't swear I do. I know what I think. I think I know what they think, but I'm not sure what they think. The second point I'd make is, this probably has an echo. This is slightly off point, but this debate about the philosophic difference has an echo of the debate that probably took place in the mid-30s on Social Security. It was mandated. And it was mandated because everybody knew you couldn't get insurance unless everybody was in the pool. And they knew if only some people were in the pool, what would happen is a lot of people, when they got old, we'd take care of them anyway, and you'd have to pay for them. So it's kind of it's not the same thing. I'm not making it exact, but it's the same philosophic debate that took place back in the 30s. But look, I think if I can lay out, Mr. President, what I think we all agree on, and then figure out whether there's a way to deal with the deficit end of this, bending the cost curve, to use the phrase you and many others have used, Mr. President. First of all, everybody agrees we have the finest docs and the finest hospitals and the finest nurses in the world. And we don't have quite enough of them, but we have the finest. Everybody also agrees, I got from this morning, but I think we had before, that Senator Coburn is right, that we waste a heck of a lot of money, and that somewhere around a third of all the dollars we spend on Medicare goes for nothing useful. The third thing it seems I assume we can all agree on is that over the last decade, costs have doubled for health care in America. Costs have doubled for government-provided health care, but everybody's health care. And that meant that right now, everybody knows that wrecks budgets. It wrecks state budgets, it wrecks family budgets, it wrecks federal budgets. Every 35 cents of every dollar spent on health care is spent by the federal government or the state governments for Medicare and Medicaid. 35 cents on the dollar. That doesn't count veterans and other things, just those two. And so, and what's happened is, on the dollar, on every health care dollar. And so we're facing, all of us around this table, Democrat and Republicans are facing the fact that there's $919 billion now we're spending on Medicare and the federal portion of Medicaid. And that if things, I don't see any firewall is going to keep costs from doubling again. We're going to be talking about in the year, 2019, we're going to be spending $1.7 trillion if we don't do something to bend that curve. So the fourth point I think we can agree on is that whether you agree how it is arrived at, CBO's gone out and scored the various plans as to whether or not they bend the cost curve. And everybody's acted in good faith. John's plan, they've gone out and points out over 20 years and I don't know if that's a Republican plan or John, I don't think there's any one plan that is out there, but John's plan cuts those costs by $300 billion over 20 years, according to CBO. The Senate plan cuts it by over $1 trillion over 20 years, $100 billion over 10. Again, we can argue on the margins, but the fact is it's not just CBO that said this. You had the Business Roundtable you had studied that shows that the Senate plan slows growth by 15 to 20%, and that business costs per employee by the year 2019 would be $3,000 less per employee. Again, it may be wrong. It may be wrong the exact amount. It may be $3,800, it may be $2,200, but it cuts costs. And so it seems to me that there is, and I might add that in the process here, it wasn't part of the, specifically part of the long-term debt debate, but, you know, as has been pointed out here, we're not cutting Medicare benefits in this. We're trying to eliminate the third of the problem that's a waste. And as Senator Enzi, who I have an inordinate amount of respect for, points out, he said it'd be nice if we put some of these savings back into Medicare. Well, the fact is we do. We close the prescription drug donut hole. We provide for preventative care for seniors, which they don't have now without a copay. And we also, it's everyone, I think most every major study agrees that it's going to extend the life of Medicare Trust Fund, and it changes these changes, the actuarial group pointed out, would save about $200 on a premium per Medicare recipient out there. The people are paying. So, look, and the source of how we do this is getting rid of waste, making sure that we don't overpay insurance companies for Medicare Advantage. I want to remind everybody about Medicare Advantage, because some of us around here, probably all of us around this table, were here when it got put in. What was the rationale for Medicare Advantage? The rationale for Medicare Advantage a decade ago was that private insurers could provide insurance, better insurance, cheaper than the government can do it. They can do it better. And we said the reason why we're going to pay them more than what they're going to give at the front end is to incentivize them to get in the business of doing it. And so we paid them $1.15 for every dollar's worth what we could have bought for $1. We did that, and it was a rational thing to try. We did that because we wanted them to get engaged in the business we thought government didn't do as well as the private sector did. Well, here we are. We're overpaying insurance companies about 15 cents on the buck that we could buy for $1, and we call for eliminating that. And so the other point I'd make, Mr. President, is that that we're in a situation here where at the end of the day, nobody in this room, I don't think anybody in this room is going to say, you know something, we are really going to be reforming the health care system without affecting the effect on the long-term deficit. Unless we bend that cost curve, we're in trouble. And Mr. President, we can argue, which we will, about whether or not the way you and I want to go after dealing with a long-term debt, whether commissions make sense, whether or not we're ever going to deal with entitlement. This is a big entitlement. It's a big entitlement. Medicare. It exists. We got to figure out how to keep it from bankrupting the country without denying seniors what they're entitled to in a nation like ours, decent health care that provides for their needs. So I'd like us, Mr. President, I'm going to hush, I'd like us to talk about, if we can, specifically, what we all agree on. What do we do about bending the cost curve? What's the best way to do it? And I yield the floor.
Mr. President.
Say as a senator?
Mr. President, Mr. Ryan's going to open this conversation on behalf of us.
Thank you. Look, we agree on the problem here, and the problem is health inflation is driving us off of a fiscal cliff. Mr. President, you've said health care reform is budget reform. You're right. We agree with that. Medicare right now has a $38 trillion unfunded liability. That's $38 trillion in empty promises to my parents' generation, our kids' generation. Medicaid's growing at 21% this year. It's suffocating states' budgets. It's adding trillions in obligations that we have no means to pay for it. Now, you're right to frame the debate on cost and health inflation. And in September, when you spoke to us in the well of the House, you basically said, and I totally agree with this, I will not sign a plan that adds one dime to our deficits, either now or in the future. Since the Congressional Budget Office can't score your bill because it doesn't have sufficient detail, but it tracks very similar to the Senate bill, I want to unpack the Senate score a little bit. And if you take a look at the CBO analysis from your chief actuary, I think it's very revealing. This bill does not control costs. This bill does not reduce deficits. Instead, this bill adds a new health care entitlement at a time when we have no idea how to pay for the entitlements we already have. Now, let me go through why I say that. The majority leader said the bill scores as reducing the deficit $131 billion over the next 10 years. First, a little bit about CBO. I work with them every single day. Very good people, great professionals. They do their jobs well, but their job is to score what is placed in front of them. And what has been placed in front of them is a bill that is full of gimmicks and smoke and mirrors. Now, what do I mean when I say that? Well, first off, the bill has 10 years of tax increases, about $500 billion, with 10 years of Medicare cuts, about $500 billion, to pay for 6 years of spending. Now, what's the true 10-year cost of this bill? In 10 years, that's $2.3 trillion. It does a couple of other things. It takes $52 billion in higher Social Security tax revenues and counts them as offsets, but that's really reserved for Social Security. So either we're double counting them or we don't intend on paying those Social Security benefits. It takes $72 billion and claims money from the Class Act. That's the long-term care insurance program. It takes the money from premiums that are designed for that benefit and instead counts them as offsets. The Senate Budget Committee chairman said that this is a Ponzi scheme that would make Bernie Madoff proud. Now, when you take a look at the Medicare cuts, what this bill essentially does, it treats Medicare like a piggy bank. It raids $500 billion out of Medicare, not to shore up Medicare's solvency, but to spend on this new government program. Now, when you take a look at what this does is, according to the chief actuary of Medicare, he's saying as much as 20% of Medicare's providers will either go out of business or will have to stop seeing Medicare beneficiaries. Millions of seniors who have chosen Medicare Advantage will lose the coverage that they now enjoy. You can't say that you're using this money to either extend Medicare's solvency and also offset the cost of this new program. That's double counting. And so when you take a look at all of this, when you strip out the double counting and what I would call these gimmicks, the full 10-year cost of this bill has a $460 billion deficit. The second 10-year cost of this bill has a $1.4 trillion deficit. And I think probably the most cynical gimmick in this bill is something that we all probably agree on. We don't think we should cut doctors 21% next year. We've stopped those cuts from occurring every year for the last 7 years. We all call this here in Washington the doc fix. Well, the doc fix, according to your numbers, cost $371 billion. It was in the first iteration of all these bills. But because it was a big price tag and it made the score look bad, made it look like a deficit, that provision was taken out, and it's been going on as standalone legislation. But ignoring these costs does not remove them from the backs of taxpayers. Hiding spending does not reduce spending. And so when you take a look at all of this, it just doesn't add up. And so I'll finish with the cost curve. Are we bending the cost curve down or are we bending the cost curve up? Well, if you look at your own chief actuary at Medicare, we're bending it up. He's claiming that we're going up $222 billion, adding more to the unsustainable fiscal situation we have. And so when you take a look at this, it's really deeper than the deficits or the budget gimmicks or the actuarial analysis. There really is a difference between us. And we've been talking about how much we agree on different issues, but there really is a difference between us. And it's basically this. We don't think the government should be in control of all of this. We want people to be in control. And that, at the end of the day, is the big difference. Now, we've offered lots of ideas all last year, all this year, because we agree that status quo is unsustainable. It's got to get fixed. It's bankrupting families. It's bankrupting our government. It's hurting families with pre-existing conditions. We all want to fix this, but we don't think that this is the answer to the solution, and all of the analysis we get proves that point. Now, I'll just simply say this, and I respectfully disagree with the Vice President about what the American people are or are not saying, or whether we're qualified to speak on their behalf. So we are all representatives of the American people. We all do town hall meetings. We all talk to our constituents. And I've got to tell you, the American people are engaged. And if you think they want a government takeover of health care, I would respectfully submit you're not listening to them. So what we simply want to do is start over, work on a clean shaded paper, move through these issues step by step, and fix them and bring down health care costs and not raise them. And that's basically the point.
I'm going to call on Javier Becerra, but I just want to follow up on a couple points. There's some strong disagreements on the numbers here, Paul, and but I don't want to get too bogged down. And first question I have is whether your side thinks Medicare Advantage is working well, because I think it's important just to point out that when we keep on talking about cuts in Medicare, what we're really talking about is what Joe alluded to, which is a decision was made a while back to set up a system in which Medicare costs, let's say, $1 under the government program that 80% of people still use and are perfectly satisfied with, and there's no showing that it's not working for them. We said we'd give it to private insurers, and we'd give them a bonus of $1.15 for every dollar in the normal plan. And it turns out that people aren't healthier because of that extra $15 or 15 cents. It's estimated that it's costing us about $180 billion over 10 years, let's say $18 billion a year. And essentially what my proposal would do, and what the House and Senate proposals would do, would say, instead of having the insurance companies get that money, let's take that money. The savings are between $400 and $500 billion a year. And let's devote some of that money to closing the donut hole, which has already been talked about. Seniors who need more prescription drugs than Medicare currently is willing to pay for hit this gap where suddenly they've got to use it out of pocket, and they just stop taking the drugs, or they break them in half, or what have you. Let's fill that. That costs around $30 billion a year, or $300 billion. And let's make some other changes that would result in actually the 80% of seniors who aren't in Medicare Advantage getting a better deal. So we can address some of the broader issues, but I just want to focus on Medicare Advantage because I haven't seen an independent analyst look at this and say seniors are healthier for it or taxpayers are better off for it. That's what we're talking about reforming. We're not talking about